E antigen will come back and their DNA will come back over 5 years. So it's not really a good long-term strategy. I mean, what Nid's talking about is a sort of a slingshot thing. When you stop therapy, allow the virus to flare, you're getting an immunologic stimulation. So if you can slingshot that up a little bit higher, maybe you can clear more S antigen. That's a different perspective. But just stopping, on its own, I think is really dumb. And this is the predictors of retreatment. And I think you've kind of heard Nid talk about this. Pre-stop surface antigen less than 100, which means they're going to clear anyway, frankly, because that's so low. Core antigen undetectable, and then this is core antigen over here. So multiple small studies showing undetectable core or S at the time of stopping have a lower chance of relapse, which makes sense. The risk of HCC persists on therapy, actually. Without cirrhosis, it's pretty low, but with cirrhosis, even though we keep them undetectable for this study is for a long time, 8.4 years. I've got people I've followed for 12, 15 years, little old Chinese ladies who came to me with lamivudine-resistant hepatitis B who had decompensated cirrhosis. We treat them. Actually, they recompensate. Their ascites goes away. Their liver gets better. Their fiber scans are normal. And we're still screening them for HCC because they had cirrhosis when they started, okay, and their risk for liver cancer remains. So we still have to be sort of forever vigilant in these patients like we do in many of the hepatitis C patients. And then this is mostly for our fat American patients with hepatitis B, actually. That is, if you have NASH and hepatitis B, or fatty liver and hepatitis B, they make each other worse. So I think that's probably pretty obvious. You have two diseases that one. So we have a lot of our American-born Asians that are assumed the McDonald's diet, okay, are getting fatter as well as having hepatitis B, and it's a problem. I've got many of those as patients. Now let's talk about money for a second. I know you guys don't like to talk about money, but healthcare utilization costs here. This is actually done in an insured national sample of U.S. patients. A lot of patients in this number in this study. I think this is the bottom line here. This is $20-15. This is compensated liver disease, so no decompensated cirrhosis, so no transplant, et cetera, et cetera. And versus the control group, this is Medicare costs here. So actually, just having the presence of hepatitis B causes your all-cause healthcare costs to be triple, more than triple that of patients who don't have hepatitis B. So this should get some of the insurers' attention, actually, when we're talking about new therapies for hepatitis B, because if we can actually clear their S antigen, we can actually then stop their therapy. Okay, so in the U.S. in the last couple of minutes, 70% of people are not aware. In care, 2.5% of the patients in the U.S. with hepatitis B are getting treated. I think 2.5% now. This is mind-boggling. There's like less than 100,000 prescriptions being written for hepatitis B treatment in the U.S., and the vast majority are being written by Asian primary care docs, Chinese and Korean primary care docs. This is the hepatitis B patients never being monitored or routinely being monitored for hepatitis B. DNA, 62%. Liver histology, obviously you don't need to biopsy people with cirrhosis, but you do need to screen them for HCC. And even patients with cirrhosis, 62% of them have not been surveilled for HCC over the last 5 years. I mean, these numbers are just mind-boggling. So we need to screen everybody. We kind of talked about this before. We want to make their virus negative, which will normalize their ALT, their E antigen loss, with or without seroconversion, and S antigen loss or seroconversion, which will all actually result in much better livers for everybody. And the best predictor of sustained remission off treatment is S antigen loss. You don't have to have an antibody, you just have to lose the S antigen. So long-term antiviral treatment, risk reduction, For liver disease, 81%, 91% for HCC, not zero, doesn't make HCC zero, but a long time. And relapse rates, if you stop actually with nothing to back it up, you know, an agravir to back it up here are 70, 50, and 60 here, 60% in all patients. This is HCC surveillance. We don't have to go into the details there. Everybody with HCC, with hepatitis B should be screened. Cirrhotics, actually more careful. So identify people, prevent new infections, vaccinate everybody. We can prevent liver cancer. This is the first vaccine that can prevent cancer. This hepatitis B vaccine. So all of you who are 29 years old or older may not be vaccinated for hepatitis B. So go get vaccinated for B and A, actually, so you can eat at the dirty deli downstairs and not have it work. So I think, yeah, we're just on time, actually. We're good.